Good morning, good afternoon, good evening. My name is Lauren. I'm a member of PHM South Africa, and I'd like to welcome you to this webinar on CHW's experiences during the COVID-19 crisis. Before we start, I'd like to hand over for a brief announcement about interpretation.
Deepika, can you do the Hindi one? Dear friends, there will be interpretation available today. We will be having interpretation in English, French, and Hindi. We will also make the announcement again in these languages. We will be having Sureka speak in Hindi, so all the English speakers would have to log into the interpretation and go to the English channel. Similarly, the French and Hindi listeners will have to go to the respective channels, which is at the bottom of your screen, and you will see a globe where it reads as interpretation. This announcement will be now made in French and Hindi. I'll ask Audrey to do the French announcement.
Bonjour, cette réunion avec des services d'interprétation en français. Pour vous connecter à l'interprétation, veuillez cliquer sur le globe terrestre qui se situe en bas de votre écran, sélectionnez français, puis terminer. Merci.
Audrey, you also seem to have logged your interpretation account in English. You might have to just change it to French. Deepika, could you go ahead? Or Sulakshana, could you make the Hindi one? I can't hear Deepika.
हमने जो है हिंदी में भी अनुवाद का व्यवस्था किया हुआ है, तो अगर आप अपने उसमें जूम ऐप में जाएंगे, वहाँ इंटरप्रिटेशन एक गोलाकार सा एक वो चिन्ह बना हुआ है, जिसमें आप उसमें हिंदी जहाँ लिखा हुआ है उसको आप टिक उसके ऊपर क्लिक कर सकते हैं, और उससे जो है जो हम जो जब इंग्लिश या किसी दूसरे भाषा में बात होगी तो आपको जो है हिंदी में ही वो चीज़ सुनाई देगी। और अगर आपको कोई दिक्कत है तो आप चैट में लिख के पूछ सकते हैं। थैंक यू।
Thank you, Sulakshana. So I would like at this time to introduce Dr. Helen Schneider, who will be moderating for us, and who is a professor at the University of the Western Cape, here in Cape Town, where I'm also based. And also, just before handing over to Dr. Schneider, I'd just like to indicate that the Health Systems Thematic Group of PHM helped to organize this. And so thanks to Sundar, Sulakshana, Deepika, Linda, and Matthias for all their work on this. Dr. Schneider, over to you. Thanks.
Thanks, Lauren. And very warm welcome and greetings to all of you, comrades, friends, colleagues from wherever you've joined us in the world. As Lauren said, I'm Helen. I'm from the School of Public Health at the University of the Western Cape, which was the school founded by the late David Saunders that many of you would have known. I'm particularly delighted to be joining today and to be moderating your session. This webinar, in contrast to the many, many conversations happening on community health worker programs across the globe, is refreshingly different. It's different because it's presenting the perspectives and voices of community health workers themselves, their issues, their challenges and struggles for recognition, many of which have intensified during the COVID pandemic. So in our lineup today, we have the very good fortune of being joined by community health workers who've played leading roles in the struggles of community health workers for rights and recognition, and who will reflect on these struggles, but in particular, the experiences during the last year and a half under COVID. These community health workers, as Sulakshana, I think, will show us a slide, come from all over the world: India, Malawi, Australia, South Africa. We will also see recorded video messages from community health workers in Brazil and Philippines. And we will have representatives of Public Services International, a global federation of public sector unions from the Asia and Pacific offices addressing us. So in the first part of this webinar, we will ask each of those panelists to give us a short input and provide us with their perspectives, which we hope will provoke ideas, comments, questions from you, which you should post in the Q&A or in the comments box. And then in the second part of the webinar, we'll have a chance to engage those comments and questions with the panelists. In the third part of the webinar, we will then turn to considering what all of this means for PHM going forward. Before I hand over to the first speaker today, I think it's important to acknowledge that the term community health workers covers a wide variety of roles, training, employment, status, and levels of integration in health systems. And the many, many names given to community health workers across the globe reflect something of this diversity. But despite this huge diversity, community health workers across the globe are united by their structural position between the formal health system and communities, and their role in navigating that interface, playing some combination of what colleagues Marta Scharf and Steph Top have referred to as service extender, cultural broker, and social change agent. And I think we'll be hearing a lot more about those different kinds of roles today. Community health workers also share a common challenge. There's an increasing reliance on their work and a growing rhetoric in health systems of their importance by managers and leaders. But this is often poorly matched with their everyday experiences of that health system. And we need to explore those contradictions today as well. So without further ado, I'd like to now introduce our first speaker. I think, Sureka, you are ready to talk to us. Sureka is from Haryana State in India. She's the General Secretary of the ASHA Workers Union, so the Community Health Worker Program in India. She's also the president of the Center of Indian Trade Unions in Haryana and a member of the All Indian Coordination Committee of ASHA workers. So she's going to be speaking to us about how COVID-19 has exacerbated all the challenges faced by the ASHAs in India. Thank you. Sureka, over to you. And I should just add that Sureka is speaking in Hindi, so please switch on the translation channel as she begins.
नमस्कार सभी पैनलिस्ट को और सभी दर्शकों को जो मेरी बात सुन रहे हैं। और आज हम काफी मुश्किल दौर से गुजर रहे हैं और जब हम जनता की सब लोग ही काफी मुश्किल दौर में हैं, उस समय पे जो स्वास्थ्य कार्यकर्ता हैं, जो कम्युनिटी हेल्थ वर्कर्स हैं, कम्युनिटी हेल्थ वर्कर्स की, आशा वर्कर्स की बात करेंगे, जो स्वास्थ्य विभाग में सबसे निचले पायदान पे काम करते हैं, तो ये चुनौतियां कई गुना और ज्यादा बढ़ जाती हैं। इससे पहले भी जब कोविड नहीं था तभी भी, क्योंकि आशा वर्कर्स भारत देश में स्वास्थ्य विभाग के सबसे निचले पायदान पर काम करती हैं, तो इसलिए उनको पहले से भी काफी ज्यादा चुनौतियों का सामना करना पड़ रहा है। भारत में जो आशा है वो काफी तरह के स्वास्थ्य 40 अपनी ड्यूटी जिनमें कर रही थी कोविड से पहले, जिसमें एंटीनेटल केयर, पोस्ट नेटल केयर, इम्यूनाइजेशन, फैमिली प्लानिंग जैसे ट्यूबरक्लोसिस के जितने भी प्रोग्राम है वो, हेल्थ सर्वे, सैनिटरी से संबंधित बहुत सारे काम हैं जो आशा पहले कर रही थी। और वही जो वर्कलोड था आशा के पास, वो काफी वर्कलोड था। उसके मुकाबले में उनको जो दिया जाने वाला इंसेंटिव्स है वो काफी कम इंसेंटिव्स थे। और हम ये बार बार बात उठा रहे थे कि जब ये NHM प्रोग्राम देश में शुरू हुआ था तब कुछ इंसेंटिव्स तय किए गए थे, उसके कई साल बाद तक वो इंसेंटिव्स को रिवाइज भी नहीं किया गया था। तो हम ये चाह रहे थे कि आशाज के लिए वेतन भी होना चाहिए, ऑनरेरियम भी होना चाहिए, इंसेंटिव्स भी होने चाहिए। उसके लिए हम संघर्ष कर रहे थे और संघर्ष करके हमने कुछ कामयाबी हासिल की। जब ये कोविड आया तो कोविड की फर्स्ट लहर में ही आशाओं को जो काम दिए गए कि उनको कहा गया कि आप कॉन्टैक्ट ट्रेसिंग का काम आप करेंगे, आप हेल्थ सर्वेक्षण करेंगे, आप ये जांच करेंगे कि कौन हाई रिस्क लोग हैं, कौन एरिया से बाहर जा रहे हैं, कौन जिनकी एंट्री यहाँ पे हो रही है। फिर जो लोग सिम्टोमेटिक्स थे उन सिम्टोमेटिक्स लोगों तक की जानकारी हेल्थ डिपार्टमेंट को पहुंचाना, उसके साथ साथ में उनको जो बाहर से आते हैं उनके लिए क्वारंटीन रहने के लिए उनको मोहर लगाना, घरों पे उनके पर्चे चिपकाना। और यहाँ तक की भी ड्यूटियां आशाज को यहाँ पे दी गई हैं कि पुलिस पोस्ट पे भी आशाज को अपॉइंट कर दिया गया है कि आप अपने एरिया के हर व्यक्ति को जानते हैं तो आप यहाँ पुलिस पोस्ट पे ड्यूटी करके आप बताइए कि ये जो लॉकडाउन में एंट्री मांग रहे हैं गांव के अंदर आने के लिए, शहर के अंदर आने के लिए, ये यहीं के रहने वाले लोग हैं कि ये नहीं है। कुछ हाई रिस्क लोगों की पहचान के लिए भी अलग से भी सर्वे करवाए, कोई शुगर का पेशेंट है, कोई कैंसर से पीड़ित है या इसी तरह से। फिर उसमें बच्चों के उम्र के हिसाब से कई तरह के सर्वे जो हैं आशा वर्कर्स ने उस समय पे किए थे और काफी गंभीरता से ये काम तमाम किए। और ये काम जो है, जो पहले से आशा जितना काम कर रही थी उस काम में हम ये कह सकते हैं कि डेली का 4 से 5 घंटे का काम आशाज का अतिरिक्त बढ़ गया। और उस वो डेली 4 से 5 घंटे जो अतिरिक्त बढ़े उसके लिए आशाज को जो इंसेंटिव्स में बढ़ोतरी हुई, वो इंसेंटिव्स में बढ़ोतरी केवल 1000 पर मंथ के हिसाब से वो बढ़ोतरी उसके अंदर हुई है, जो कि काफी हम कह सकते हैं कि काफी कम है, नॉमिनल है। फिर भी आशाज ने काफी खुशी से और ये समझ के कि आज जो है पूरी दुनिया के ऊपर ये एक संकट है महामारी का। कोई बात नहीं बेटा, नहीं है, प्लीज मैं बात कर रही हूँ। मैं पिंकी क्या है, सॉरी फॉर डिस्टर्बेंस, सॉरी। तो अभी ऐसा ये प्रॉब्लम चल रही थी कि हम ये तमाम काम कर रहे थे और ये सोच के कर रहे थे कि पूरे देश के ऊपर महामारी आई हुई है और इस महामारी से हम सबको मिलके मुकाबला करना है। लेकिन कम्युनिटी के स्तर पे हम लोगों को काफी चुनौतियों का सामना करना पड़ा ये काम करते हुए। और वो इस तरह से कि जब हम गांव के अंदर जा रहे थे तो क्योंकि काफी वीकर सेक्शन से बिलोंग करती हैं आशाज, उनका जो इनकम जो स्टेटस है जो वो भी काफी लोअर है। तो जो लोग थोड़े से हाई पावर्ड लोग थे उन लोगों ने थोड़ा सवाल उठाया आशाओं पे कि कैसे आप हमारी आ सकते हमारे घर पे बार बार ये पता करने के लिए, या हमारे घर पे पर्चा कैसे चिपका सकते हैं, पोस्टर कैसे चिपका सकते हैं। इस बात के लिए आशा वर्कर्स को मारपीट का सामना करना पड़ा। न केवल आशा वर्कर्स को करना पड़ा बल्कि उनके फैमिली मेंबर्स तक, कुछ केसेस तो ऐसे हैं 3-4 यहाँ पे कि जिनमें उनके फैमिली मेंबर्स को भी गंभीर चोटें आई, वो घायल तक हो गए। लेकिन जो सरकार का रुख था, वो ये भी काफी दुख के साथ मैं शेयर कर रही हूँ अपने इंडिया के बारे में, अपने कि यहाँ पे एक क्रिमिनल माहौल भी बना जो फर्स्ट वेव थी उसके अंदर, और उसमें फिर रिलीजियस बेस पे भी कुछ जो है अटैक हुए कई जगह पे। हमारी आशाज पे भी कई जगह पे उस तरह से उनको उसका सामना करना पड़ा उस प्रतिक्रिया का। तो ये तमाम समस्याएं थी। इन तमाम समस्याओं से जूझते हुए हम काम भी कर रहे थे, और उससे भी बड़ी जो समस्या हमारे सामने आई वो ये आई कि यहाँ पे हम लोगों को ग्लव्स, मास्क, सैनिटाइजर्स वगैरह भी नहीं दिए गए। जो कंटेनमेंट जोन थे वहां पे आशाज की ड्यूटियां लगाई गई, तो उसमें पीपीई किट नहीं प्रोवाइड करवाई गई। उसके लिए हम लोगों को स्ट्राइक तक करना पड़ा, और स्ट्राइक करके हम लोगों को ये डिमांड करनी पड़ी कि अब ये हमें डिमांड करनी पड़ी इस तरह से कि भाई ये हमें दिया जाए, इसकी हमें जरूरत है, इसके बिना हम काम नहीं कर सकते। तो कई दिन की स्ट्राइक के बाद जाके हमें ये उपलब्ध हुआ। अब जब सेकंड वेव आई तो सेकंड वेव इंडिया के अंदर जैसी फर्स्ट वेव थी उससे भी ज्यादा मुश्किलों का हमें उसमें सामना करना पड़ा। संक्रमण की दर उसके अंदर बहुत ज्यादा थी, और उसी वजह से डेथ रेट भी है वो भी काफी ज्यादा था। लोगों को ऑक्सीजन नहीं मिल पा रही थी, गांव के अंदर जो है स्वास्थ्य की फैसिलिटीज नहीं थी। तो ये कहा गया कि गांव के अंदर ही जो है आइसोलेशन सेंटर बनेंगे, वहीं पे कोविड का जो इलाज होगा गांव के अंदर, और जो आशा जो है उस जो आइसोलेशन सेंटर होगा उसकी जो है नोडल ऑफिसर होंगी, तो वो वहां पे देख रेख करेंगी। बाकी और लोगों को भी उसके अंदर अटैच किया गया कि जो हमारे मिड डे मील वर्कर्स हैं वो वहाँ खाना बनाएंगे, जो सफाई कर्मचारी हैं वो सफाई करेंगे। लेकिन वहाँ पे इंफ्रास्ट्रक्चर कुछ नहीं दिया गया, कुछ उपलब्ध नहीं करवाया गया। तो इस तरह से हम ये देखते हैं कि काम तो बहुत ज्यादा दिए गए, लेकिन उन काम के बदले में जो सबसे निचले पायदान पे वर्कर्स हमारे काम कर रहे हैं उनकी केयर टेकिंग जो होनी चाहिए थी वो नहीं हुई। यहाँ तक कि हमारे यहाँ पे एक इंश्योरेंस की घोषणा हुई। स्वयं हमारी जो वित्त मंत्री हैं निर्मला सीतारमण जी, उन्होंने कहा कि जो हमारे फ्रंट लाइन वर्कर्स हैं हम उनके लिए जो है 50 लाख का बीमा देंगे। लेकिन फर्स्ट वेव में इस तरह से ये चुनौती हमारे सामने नहीं आई, लेकिन सेकंड वेव में काफी जो हमारी कम्युनिटी हेल्थ वर्कर्स हैं, जिसमें आशा भी हैं, जिसके अंदर एएनएम भी शामिल हैं, काफी डेथ हुई हैं, और उन डेथ पे कोई जो इंश्योरेंस है वो नहीं दिया गया है। अभी हरियाणा में किसी भी जो आशा को इस तरह से वो क्लेम नहीं हुआ बीमा। कुछ हमारे और डॉक्टर्स की भी डेथ हुई है, कुछ एएनएम की भी डेथ हुई है, वहां पे नहीं हो रहा। अब जब हम उसको क्लेम करने के लिए हमने बात की है, तो ये कहा कि जो विसरा की रिपोर्ट है, यदि उसके अंदर डेथ के बाद यदि पोस्टमार्टम होगा, पोस्टमार्टम में
रेखा जी
यदि
एक छोटा सा सजेशन है कि आप थोड़ा धीरे से बोलिए क्योंकि लोगों को समझ में नहीं आ रहा।
ओके, सॉरी।
तो थोड़ा सा धन्यवाद।
हाँ जी। तो जब हम ये क्लेम हमने किया बीमे का, इंश्योरेंस का आशाज के लिए उनकी डेथ पे, अब सरकार ने कहा कि विसरा की रिपोर्ट के अंदर यदि पोस्टमार्टम की रिपोर्ट के अंदर कोविड रीजन होगा डेथ का तो हम ये क्लेम देंगे, अन्यथा हम नहीं देंगे। ऐसे काफी वर्कर हैं जो कि कोविड पॉजिटिव थे, उनको ब्रीदिंग प्रॉब्लम्स हुई, वो हॉस्पिटल्स के एडमिट हुए, वो वेंटिलेटर पे रहे, ऑक्सीजन पे थे, और उनकी डेथ हो गई। लेकिन उनकी डेथ को काउंट नहीं किया गया कोविड की डेथ में, और इसीलिए हमें संघर्ष करना पड़ रहा है कि उनकी फैमिली को किसी तरह की कोई भी राहत हम सेकंड वेव के अंदर तो और भी ज्यादा, जो पहली वेव में कुछ चीजों को थोड़ा सा गंभीरता से लिया गया था, लेकिन अब सेकंड वेव में उन चीजों को उस तरह से गंभीरता से नहीं लिया गया। और वैक्सीन पे भी यहाँ पे हमारे एक इशू बना कि जो कोवैक्सीन थी उसके 3rd ट्रायल नहीं हुए थे, खुद विशेषज्ञों ने ही उस पर एक शक जाहिर किया था और उस पर चिंता जताई थी कि थर्ड ट्रायल हुए बगैर हम कैसे अपने जो हेल्थ वर्कर्स हैं उन तक ये कैसे दे सकते हैं वैक्सीन। लेकिन फिर भी वो वैक्सीन दिया गया तो उससे लोगों के अंदर कुछ उसके साइड इफेक्ट्स भी आए। इस गंभीरता से जवाब देना चाहिए था, उस गंभीरता से वो जवाब
Sureka, I wonder if we could stop there. And pick up, you raised you.
Okay.
And to pick up some of these absolutely crucial points in the discussion. So thank you very much for your input. Yeah, and I think what you reflect is the struggles of community health workers actually across the globe. The being at the forefront of the public health response to COVID without sufficient protection, PPE, having to be co-opted in some of the coercive measures of the state, but at the same time facing the violence of community and the devastating, being really at the forefront of experiencing the most devastating impacts, particularly in the second wave. All the while not being able to do the work that you normally do. So thank you very much for that. I'm now going to hand over to Dixon Namsimwa. Dixon is from Malawi. He's a community health worker in that very well-known program in Malawi. And he's going to be talking about issues faced by community health workers during COVID and the mobilization and advocacy for safety and working conditions that they have embarked on. Over to you, Dixon.
Thank you so much. Good afternoon from Malawi. For sure, I'm Dixon Nansima. I'm the senior community health worker working with the Ministry of Health. Maybe I'll share some of my duties as I perform day by day. Being the senior community health worker, I also do supervision to other community health workers. I do immunizations to under 5 children. I do inspections in terms of sanitation and hygiene in communities. I also do follow-ups to pregnant women in the postnatal mothers, so that we identify maybe danger signs when they are there, so that we refer them accordingly. To talk about COVID-19 and mobilization of resources and other things, in Malawi, COVID-19 was firstly realized, or the first person was diagnosed in April 2020. From that time, we've been seeing a lot of cases arising. And right now I'm talking, we have already registered about 43,000 cases of COVID-19, and over 1,300 cases, people have died of COVID-19. As community health workers, we have been involved so much in this activity of trying to reduce this pandemic in our country. The first thing that you have been assigned as community health workers is to make patient follow-ups. We go in the communities and find these patients in their homes, so that we advise them we advise them how they can stay safely, and how they can stay without transmitting the infections to other household members. So we also make sure that these patients are having adequate PPEs like masks, so that all the time they don't transmit this virus to other people. And the other thing that we do is to make contact tracing when the person has been diagnosed with this virus, we also make sure that his or her contacts are not getting this infection from the patient. So we go there, we advise them what to do. We advise them to stay at a distance all the time. We advise them to use some of the things so that they don't share, like washing materials and all other things. So all these are things we make sure that they don't contact the virus. Now, all these things that we do, there are a lot of issues that we meet as community health workers. At first, when the disease was diagnosed in Malawi, it was tough because community health workers would not get anything in terms of PPEs. We do not have maybe even masks, even gloves. When going to reach these patients, we could go there and chat with them or handle them without masks. So community health workers would raise their voices to say, no, we are also putting ourselves in risk. So you need to provide us with other things. So the government tried to listen little by little. They tried to provide us with some masks, gloves, and other things. On top of the things that we do, we also do vaccination. As all the governments in the world are trying to vaccinate their people, community health workers also do these things in Malawi. We go there in the fields, in the communities, and vaccinate people with this vaccination. And also the other things that we do when we go there, we also do disinfection. We have got different places that we do. In schools, it was some point schools were closed just because the cases were just too high. So as government sat down, they had to reopen the schools. Community health workers would go there and spray all the places, all the churches, and all the places that a lot of people gather, so that the infection is reduced. Again, when we go in the communities, we also do awareness. In Malawi right now, some of the communities do not even believe that there is COVID-19. They still do things as normal, as business as usual. They still not observe social distance, even physical distance. They don't even mind not to wash their hands. They do things as normal. So community health workers are assigned to go in the communities and bring awareness to the community so that they take themselves carefully, so that they don't contract this disease, this virus of corona. Now, all these things that I've mentioned, it has been a very, very big task to the community health workers, but we are facing a lot of challenges to perform all these duties. Right now I'm talking, some of the community health workers are not employed. They're working as volunteers. They don't get even a salary after the month, even any incentives so that they can perform effectively. So it's a very big challenge. You'll find that maybe instead of maybe going to visit a patient with a COVID-19 patient, you would want maybe just to call and find out how she or he is feeling. You need to call, you need to use airtime, but you are not provided with airtime. Some of the patients, they stay very longer, maybe 5 to 10 kilometers radius, so that you cover them. You are not provided even a push bike. You walk on foot. So it's a very, very big challenge. All those things is just community health workers in Malawi are committed to save their people, but they are not supported. Again, you'll find that to those who are working, because some community health workers are employed in non-government organizations, even in government. But if you look the salaries, they're just very little. They cannot take them even a month. It's hand to mouth. But if you look the duties that they do, it's just huge comparing to what they do. So You can even see sometimes some of the top managers, maybe bosses, they don't even recognize that the community health worker is doing something that will bring them where they are. If you talk of this, maybe they call lunch allowance. Maybe you have performed a certain duty somewhere. They will tell you that this your allowance will not get it right now. Maybe you get it after 2 to 3 months. You wait for funding. But if you look to them, they are getting it every month. But the community health worker is not getting it every month. And if you go there to ask, if you go there to ask for that, sure. So should I stop there?
I think, let's stop there. Thanks, Dixon. So very similar themes from Malawi in one of the oldest, actually, community health worker programs on the continent, the health surveillance assistance. And, lots to pick up on there. And would be interested to know how you have worked collectively, actually, as community health workers to raise these challenges, as you alluded to at the start of your input. So thank you very much. We're going to now move on to a video presentation from Brazil, from the very well-known Brazilian program, the Family Health Teams. And this video is of a community health worker who will be introduced by Mateus Falcao. Over to you, Mateus.
Thank you very much, Helen. Greetings, everyone. Great to be here. I am Mateus from PHM Brazil. I'd like to share that we have, since democratization in 1988, a universal access health system here, the SUS, which stands for Unified Health System, a game-changing system that has improved a lot of people's health. Primary health care is the very base of the SUS. We even call it here basic care. It's centered at basic health units, the primary health care facility, and community health agents are part of this team and play an essential role in realizing right to health and the principles of Almata by doing challenging and inspiring work every day. Katia Kalaji, the following speaker, is one of them. She's based in the southern city of Porto Alegre. We thank her so much for sharing a bit of this experience with us today. So thank you, Katia. Going ahead.
Tá, vamos. Bom dia, pessoal. Meu nome é Katia Kalaji, sou aqui da UBS Santa Cecília, em Porto Alegre. Eu trabalho como ACS há 8 anos e eu vou falar um pouquinho dos ACS, que são...
Is the audio coming through? Can someone confirm that?
Yes, it is.
Yes.
Yeah.
Okay, thank you.
Que é a saúde batendo na porta dos usuários. Nós fizemos parte de uma equipe que a gente chega na comunidade, nós somos os olhos da comunidade para a UBS, né? E assim a gente se responsabiliza de fazer ações, né? E prevenções nas comunidades, tentando fazer diminuição do fluxo de gentes nos atendimentos de acolhimentos dentro das UBSs e emergências hospitalares. Os nossos desafios são vários: identificar as dificuldades das famílias nas comunidades, né? Ver o saneamento básico em geral da comunidade. Fizemos várias campanhas de prevenções e campanhas de ensinamentos, campanhas de acolhimentos. E dentro dessas campanhas, umas que eu posso dar de exemplo é da LGBT+, que é a campanha de conscientização às pessoas, né, sobre questões de identidade de gênero, né, para elas conseguirem entender esses conceitos. Fizemos também do Outubro Rosa, que vem falar do câncer de mama, Novembro Azul, que é o de próstata, E assim vai. Cada mês é uma coisa que a gente fala, entra em debate, faz reuniões, leva até a comunidade. Também posso falar que a gente, nas comunidades, trabalha com terapia comunitárias, né? É um trabalho lindo, maravilhoso, que é um dos que eu mais gosto de fazer, que é um trabalho que é direto mesmo na comunidade. Esse trabalho é feito em praças, normalmente, ou igrejas próximas, onde a gente consegue reunir um grupo e ali ter essa troca, vamos dizer assim. Participamos também de várias reuniões de redinha, PSE, conselho local, distrital e municipal, que é uma coisa que a gente foi muito atuante. Atualmente a gente não está tão atuante em função de pandemia, né? Trocas de conselho. Mas eu posso dizer que é a voz da comunidade, o conselho local, onde a gente consegue debater, fazer projetos, falar sobre saúde, falar sobre saneamento básico. Tudo é dentro começa num conselho local, que é dentro de uma unidade, né, de uma UBS, e vai extinguir até lá o conselho municipal. Agora em 2020, né, questão de pandemia, nós, agente comunitário, não estamos conseguindo mais sair para a rua. Então a gente está fazendo os serviços, né, internos aqui, ajudando no acolhimento, né, a famílias que queiram falar sobre suas dificuldades, abordagem na porta, abordagem na vacina, triagem no acolhimento COVID, serviços administrativos, como atender telefone. Daí a gente ficou um pouco mais interno aqui dentro, mas não que não tenha trabalho. Gente, aqui dentro eu acho que tem mais trabalho do que na rua. E assim, para não me estender muito também, quero falar um pouco do que está acontecendo, né, com os agentes comunitários aqui de Porto Alegre. O IMESF foi extinto, né, sendo assim, pelo instinto, sendo assim a equipe toda já foi demitida. Os únicos que ainda estão trabalhando para o IMESF é os agentes comunitários e EDMIAs, mas sendo que todo esse tempo que a gente está trabalhando, a gente ficou sem vale alimentação, sem aumento, reajuste salarial, numa situação que, infelizmente, mentalmente, além de tudo, nos prejudicou bastante. Muitos ACS estão adoecidos, né, nessa questão. E aí eu fico pensando, né, o SUS é tudo. O SUS é tudo. Quem tem SUS tem tudo. E como eles estão fazendo esse recauchutamento com a gente que trabalha com a saúde pública das pessoas, e os nossos governantes fazendo tanta barbaridade assim que nos adoece muito mais. Mas mesmo assim somos fortes, né? Guerreiros, estamos na luta, continuamos, não desistimos. Essa função é que eu escolhi para mim. Quando eu fiz o concurso, podia ter feito vários, mas não queria sim ser agente comunitário e consegui ser. Tento dar o meu melhor aqui dentro, né? E eu acredito que os meus colegas também, não estou falando só por mim nesse momento. Só queremos que nos valorizem um pouco mais, né? Um pouco mais de valorização em questão trabalhística, né? Não, porque em questão de usuário a gente já é bastante valorizado. Cada vez que eles vêm nos agradecer por alguma coisa que a gente tenha feito, beneficiado eles, a glória não é deles. Eu posso te dizer que a glória é nossa, porque enche meu coração de alegria ver alguém contente. E pensando em tudo isso que eu falei, não sei, eu fui muito breve. Eu vou acabar dizendo uma frase assim para vocês, que eu acho ela bem legal, sabe? Eu leio ela muitas vezes ao dia. Às vezes a gente vence e às vezes a gente aprende. Então eu me considero uma vencedora e uma aprendiz todos os dias, porque toda hora eu estou vencendo e aprendendo, vencendo e aprendendo. Gente, fiquem bem, uma ótima semana a todos.
So inspiring words there from Brazil. When all the other health workers have left, the community health workers remain. And yeah, experience at the same time the profound impacts of a deeply inimical and unfavorable political context in which workers are currently functioning in Brazil and in many parts of the world. So I would now like to also just acknowledge everyone who's introduced themselves in the chat box. We have people from the DRC, Australia, South Africa, Philippines, Mozambique, Nigeria, Sri Lanka, Malawi, and US, and probably others as well. So welcome to all of you. I am now going to invite Carl to address us. Carl Briscoe is from Australia. He's the CEO of the National Association of Aboriginal and Torres Strait Islander Health Workers and Practitioners. And he's going to be talking about lessons from the Aboriginal Community Health Worker Program. Over to you, Carl.
Thank you, Helen. Yalada Yundo. Hello, everyone. I'd like to start by acknowledging the traditional lands of the Ngunnawal people, where I'm zooming in from tonight. Oh, well, it's night in Australia. I recognise the many rivers, mountains, and landscapes and the winds that blow over our ancestral lands, which remain under our continual custodianship. I'd like to also pay my respects to elders, past, present, and to our future leaders, yet to come, and all Indigenous peoples online today. So my name's Carl Briscoe. I'm a Guuga Yalanji man from the Mossman Daintree area in far north Queensland, Australia. I've been honoured to be working on the lands of the Ngunnawal people in Canberra as the CEO for 5 years of the National Association of Aboriginal and Torres Strait Islander Health Workers and Practitioners, which has around 2,500 members, 1,000 being Aboriginal and Torres Strait Islander health workers and practitioners. The Aboriginal and Torres Strait Islander health worker and practitioner, which I'll refer to in Australia, are our community health workers, and are very much the first point of clinical and non-clinical contact with our Indigenous peoples when accessing healthcare services. They are comprehensively trained in primary healthcare, in the prevention of, in preventative health, including looking at the social and cultural determinants, health education, health promotion, as well as providing primary healthcare management and treatment of health conditions. Our Aboriginal and Torres Strait Islander health workers and health practitioners, they ensure the cultural safety of our Indigenous peoples when they access healthcare services. The workers work in our communities and they have a cultural intelligence that no other mainstream service has. They know our community, they are from our community, they are advocates and support our people when accessing health services. So from the outset of COVID-19, we saw this as a direct attack, on the human race, specifically in keeping our Indigenous people safe, especially our elders and elderly. Given Indigenous peoples are at higher rates of health conditions compared to the rest of the population. Our Aboriginal and Torres Strait Islander health workers and health practitioners are ensuring our traditional knowledge holders, our elders and elderly, who are the universities and libraries of our Indigenous communities. They're ensuring that they are protected in order to pass down their wisdom and expertise to the next generation. During the COVID pandemic, in order to support our Aboriginal and Torres Strait Islander health workers and practitioners, we developed and co-branded with our Indigenous doctors, Indigenous nurses, and Indigenous allied health peak national bodies a series of posters to support our professions as well as our community. We developed slogans such as elders respected, not neglected, proper distance for resistance, and be smart, stay apart. These resources were really well received and provided our Aboriginal and Torres Strait Islander health workers and health practitioners with health information and health education to both the professionals and our Indigenous peoples. These are available on our webpage. If you'd like to access them, you can download them in A3 and A4. During the pandemic, we witnessed a rise in racism impacting our Indigenous peoples accessing healthcare and receiving healthcare. We joined with other organisations to call for a national response to address these deplorable behaviours. We held a series of online webinars, such as we're doing tonight, and information sessions on various topics such as cultural safety during the pandemic, social and emotional well-being, online workshops to support our members. Given the rise in fear and anxiety within our members, we concentrated on addressing and providing support for our Aboriginal and Torres Strait Islander practitioners by engaging an Indigenous psychologist to work through strategies and ways of ensuring the social and emotional well-being of our workforce was being addressed. Our Indigenous leaders, they took control of protecting our communities, which has meant privileging Indigenous voices, which has led to a successful response that was largely led and delivered by Indigenous peoples for Indigenous peoples. So to date, we have not had one Aboriginal or Torres Strait Islander community death attributed to COVID-19. One of my elders, Annie Janice, said, our Indigenous peoples are used to sharing the load and helping out each other during difficult times, with COVID bringing communities and families even more closer together. With the willingness to share what we have, our non-Indigenous peoples, they look after themselves, which is not what Indigenous peoples do. We look out for each other especially in times of need. And another one of our esteemed Aboriginal leaders, Auntie Pat Turner, who was the CEO of the National Aboriginal Community Control Health Organisation, was and continues to be instrumental in protecting our community, with her wise words in protecting our elders, saying, they are our universities, they are the holders of our knowledge, our cultural history, our culture, our history, our customs, our languages. So I believe the key lessons learnt from the pandemic is honouring and respecting the voices of Indigenous peoples, providing a platform in which our expertise can be listened to and implement our advice and knowledge. Thank you very much.
Thank you very much, Carl, and for staying so expertly within the time, but also raising some really important thoughts and themes around material safety nets, but also cultural safety nets. And how COVID has at the same time revealed many of the social tensions and inequities and racism that exists. So those are all very important themes to pick up on. I'm now going to hand over to Kate Lappin and Banani Deka. They are from Public Services International and are going to be talking, I think, from a regional perspective, but also from an organizational collective action representational perspective. So over to you, Kate. I don't know how you're going to organize yourselves. You've got 10 minutes.
Thanks, Helen. Yes, well, I'll quickly start and then hand over to my colleague Banani. And if we have time, I'll come back and just speak briefly about some of the international advocacy opportunities. But if not, we can come back to them in the next session. Before I do that, let me acknowledge that I am speaking from the lands of the Wurundjeri people of the Kulin Nation in Australia, on land that has never been ceded. And I pay my respects to the elders past and present and emerging, and to Carl and to any other Indigenous leaders who might be here today. PSI is the Global Union Federation representing workers who deliver public services, whether they be acknowledged as public services workers or not. The largest area we cover is health, but we also cover all other areas of public services. I just wanted to really quickly acknowledge that the work that we've been doing with community health workers over the last few years is probably a little late from the global union movement. Obviously, community health workers have had their unions for some time, but we are more than 100 years old. And I think the union movement itself hasn't always been quick to support the organising of the most precarious workers, and women particularly haven't historically always had the most power within the union movement. And so this work that we've been doing in the last few years, in particular in our region, has been about prioritising the workers who most need support to be recognised as public health workers as they are, to be entitled to a wage, to be entitled to decent work, and to be entitled to recognition, to be entitled to a union, and to be entitled to act collectively, both in their own interests, but often in the interests of public health itself. Banani will speak a bit more about what that work specifically has been in, particularly in South Asia. But I just wanted to quickly mention that the work, of course, that we've been doing started before COVID, and started in the Asia Pacific region in Pakistan, where we really take inspiration from the unions that are affiliates to PSI that actually gained the right to be recognised, receive a wage, be recognised as public sector unions, and the struggles that they've had, the sometimes deadly struggles that they've had to achieve that, and to be able to act collectively as they have been throughout COVID, and now have joined together with other workers across India and Nepal. And this has inspired really our work to spread, to increase the amount of attention we pay to community health workers to outside of South Asia, and to Africa. I'm not at all expert on what is happening there, but we have recently started working with unions in Malawi, Zambia and South Africa, and have most recently come together with them, with the unions in Nepal, India and Pakistan, as well as some unions in the Philippines, to advocate at a global level for recognition of community health workers as public sector workers, entitled to all the entitlements that public sector workers should be. With that, I'm going to hand over to Vanani. She's really more at the coalface of supporting those workers, and she can give you a little bit more of an overview of the work that we're doing. And if we have time, then I can talk about what's happening within the World Health Organization and within the International Labour Organization to really promote the rights of community health workers in those international institutions. Perhaps Banani can take the next few minutes to really give a bit more of a picture of what we're doing.
Thanks, Kate. Thanks, everyone, and greetings from India. I'll not go much into the details of the struggles that the community health workers have been facing across South Asia and all across the country, because we have been hearing firsthand very powerful testimonies of the workers themselves, what they have been facing, especially with the COVID coming in, but these and the plights being highlighted during the COVID, but as one of our comrades have already mentioned, they are the lowermost rung of the workers who has not been recognized or regularized as public health care workers, and they are still working as volunteers and still upholding the public health care system together. So I would also want to mention that although 70% of the global health workforce is comprised of women, it's only 25% of the leadership is amongst the women. And although like the organization of the CARE and Public Services International has been coming up with the CARE manifesto that Kate would be elaborately explaining in the coming times, but I would like to more specifically dive into the campaign that we had started. It was a campaign that we started with the COVID coming in and the community health workers being the frontline responders to the work and still working throughout. We had a very short-term goal, especially because what we had seen is that the governments were not including community health workers in any of the policies or plans that they had been coming up. So our primary goal of the campaign was to fund and improve, of course, the conditions of the work, because they have been working throughout without any safety precautions or PPE, but also to include them into the COVID recovery and the COVID response and the recovery plans that have been going in and about amongst almost all the countries in Asia, and of course with a long-term goal of getting recognized for the work that they are doing and being regularized as public healthcare workers. So this was our campaign launch, but the main aspect of the campaign is that This is a campaign that we have started in 3 countries, which is India, Nepal, and Pakistan. And with our unions, we had quite a deliberation, and we came up with a joint charter of demands where we have categorized our demands into 6 areas, which firstly being several minute and very detailed demands pertaining to each country's amongst these broad demands, starting from recognition and regularization of work, where we are demanding payment of minimum wages and a decent pay to the workers with the scope for overtime payment. Then we have we have a demand for collective voice in the decision-making process, because it cannot be a top-down approach, and we need a down-to-top approach by the government. We are demanding COVID-19 to be declared as occupational disease under the demand of occupational safety and health, where we are also demanding specific facilities for the community health workers across South Asia. And yes, dignity has been one of the primary aspects of our demands, because what we have seen time and again that the community health workers have been harassed and there has been several instances of violence, and they do not have any process of addressing their grievances, be it in the also in amongst our union members and also in the official settings, because they do not have a specific workplace where we where we are demanding a specific workplace for them and care for us. And lastly, we are demanding a people-centered public healthcare system, because COVID has especially highlighted that community health workers have been the backbone of the public healthcare system, and we especially now need a more robust public healthcare system, and the government needs to invest more into the campaign. We have into the public healthcare system. With the campaign, we have also had a few successes, especially we would like to mention that in Nepal, where the community health workers are not even provided a monthly allowance, but a yearly allowance is provided to them. We have been able to demand for an increase in the travel allowance, and the government in the recent budget have, after repeated strikes and deliberations with the community health workers, have increased the travel allowance, in fact, double the travel allowance that they have been receiving. And there has been constant negotiations going on with other governments regarding their increase in the other allowances and also payments. Similarly, we also have had a very successful ILO consultation, and I would like to hand it over to Kate to dive more into the details of that. Thank you so much.
Yeah. Okay, 1 minute, Kate. Yeah.
Okay. Well, just very quickly, there are 2 big, important processes globally that we see opportunities for community health worker advocacy. One is this review of the ILO Nursing Convention and recommendation. And we've made a submission to this process from community health workers across the countries we mentioned earlier, to ensure that they can get recognition and fall under this instrument. We can talk more about that later. The other is in relation to the World Health Organization. This year has been declared the year of the health and care worker, and there's an agreement to have a global care compact. And we see that as another important venue to advocate for recognition of community health workers' rights. So I'll leave it there, and I'm happy to discuss further if there's time later.
Oh, great. Good. So delivered by women, led by men, community health workers as providing significant labour as essential workers in health systems, but still treated often as stipended volunteers. And a major challenge is how to value this work, even within, as you said, Kate, in the mainstream trade union movements to begin to recognize community health workers as having formal employment rights like other workers. So thanks for pointing us to the work you and Banani are doing, really hopeful. And there is a question which we can come back to in the Q&A about what is the potential for extending this from Asia to other continents, African continent in particular. So thank you. All right, so now we're going to hear from Philippines. We've got videos as well from community health workers in Philippines. And I'm going to hand over to Jamie Dasmarinas to introduce these community health workers. So Jamie, are you online?
Yes.
Oh, there you are, yes.
Okay, there. Okay. So good day to everyone. So I'm Jamie Dasmarinas from the Council for Health and Development, and I'll make this short. We work with this parish-based community health program here in the capital, in Quezon City, called Caritas Novaliches, and they work closely with the labor ministry of the local diocese of Novaliches, and they also have, again, a community-based health program there with the workers. So the Philippines has one of the longest lockdowns in response to COVID, but we still have a very weak health system, and our grassroots, especially our sitios, our barangays, they're the ones that suffer for it. But our community health workers still do their best to try to help out despite all of this. And I would like to introduce members from Caritas Novaliches. So we will be playing recorded videos of their testimonials. So yes. So maybe we can start playing the vids. Thank you.
Magandang araw po sa inyong lahat. Ako si Ami Labiste mula sa Caritas Novaliches, head ng Paris-based health program ng Health and Nutrition Ministry mula 2018 hanggang sa kasalukuyan, at ngayon ay program coordinator ng Labor Ministry ng Diocese of Novaliches. Nang nagkaroon ng pandemya, nakita ko na lalong naging mahirap ang kalagayan. Una, sa usapin ng pagtulong bilang CHW, mahirap ang komunikasyon. Pagtitipo na dating nagagawa, ngayon ay nagkaroon ng limitasyon. Ngunit kahit nagkaganito, nagawan at natuklasan din natin ang iba't ibang pamamaraan. Tulad ng online, pagtawag, through phone para magkaroon ng komunikasyon. Nitong taong mas lumala dahil mas tumaas ang bilang ng nagkasakit at namamamatay. Ngunit sinisikap pa rin namin makatulong bilang mga CHW. Dahil malaking tulong kami para maglinaw sa komunidad kung paano mapapangalagaan ang kalusugan. Bahagi ng kampanya sa kalusugan ang paglilinaw sa kahalagahan at pagsunod sa health protocol, contact tracing, panawagan sa pagkakaroon ng libre, ligtas at epektibong bakuna, paglalantad sa kaganapan at kalagayan ng health workers para maprotektahan sila, pagkakaroon ng mass hiring ng mga health workers, pagpapakita ng hindi epektibong pamamalakad ng pamahalaan sa problemang pangkalusugan ng bansa, pagsasawalang bisa sa anti-terror law dahil dito nagkakaroon ng takot ang maraming mamamayan. Ang kaibahan ngayon sa pagbibigay ng serbisyo, mas maraming kinakaharap na problema. Sa pag-i-area, hindi tiyak ang kaligtasan. Bagamat may online, iba pa rin ang nakakausap sila ng personal. Noong nagkasakit ako, kinaya ko naman at muli nakabuelo bilang CHW. Ngayon, dahil nasa yugto ng pagbabakuna, nakakatulong kami sa paglilinaw ng kahalagahan nito. Sa pakikipag-usap sa mga komunidad, dapat may baon kang kaalaman na ibabahagi sa kanila. Mahirap magtipon ngayon, pero sinisikap pa rin namin. Sa katunayan, ang bawat CHW ay merong pinamimigay na visual. Magsisilbi itong gabay sa pagtalakay hinggil sa bakuna. May mga face-to-face rin kami na training sa mga leader para maging speaker. Tiyagaan nga lang kasi limitado ang bilang ng dumadalo. Pinakamataas na 12 to 15 lang ang pupwede. May dinidisenyo rin kami na mga pwede sa online at face-to-face na praktikum, katulad ng pagkilala at paggawa ng halamang gamot, first aid training. Mahalagang hindi mahinto kasi ang pag-aaral, online man ito o face-to-face. Para maisulong ang karapatang pangkalusugan, mahalaga ang may alam, prinsipyado at determinado na magmulat, mag-organisa at magpakilos para makamit at maipaunawa sa malaking bilang ng mamamayan na sa lakas ng ating pagkakaisa, malalabanan ang lahat ng ito at malalampasan ito sa pamamagitan ng tuloy-tuloy na paggampan natin ng ating mga gawain. Ang pandemya ay matutugunan o ang ating pamahalaan ay bibigyang prioridad ang pangkalusugan ng mamamayan, hindi sa sariling interes. Mabigyan ng kaalaman ang lahat kung paano ang tunay na pangangalaga sa kalusugan at mauunawaan na ang kalusugan ay karapatan ng bawat mamamayan. Ang gusto naming mangyari bilang mga CHW, mabigyan ng prioridad ang programa sa kalusugan ng mamayan at magagawa ito kung ang pamahalaan ay siseryosohin ang panawagang magkaroon ng serbisyong medikal, hindi militarisasyon, bakunang ligtas para sa lahat, mas testing, itaas ang sahod ng mga health workers at mabigyan sila ng tama at makatwirang hazard pay. Dagdagan ng budget ang mga ospital para makumpleto ang mga kagamitan at magkaroon ng angkop na libreng PPE ang mga manggagawang kalusugan para sila'y maprotektahan. Magkaroon ng mass hiring ng mga health workers. Para naman sa komunidad, magkaroon ng mga information drive kaugnay sa COVID-19 at pagbabakuna, pamamahagi ng libreng face mask, alcohol at vitamin C at pantay na pamamahagi ng ayudang sapat para sa lahat. Para sa mga manggagawa, tiyakin ang kalusugan at kaligtasan sa lugar paggawa, kasiguraduhan sa kanilang trabaho at benepisyo at magkaroon ng serbisyong transportasyon, papasok at pauwi. Ang mga lawanan ng trabaho ay magkaroon ng ayudang 10,000 kada buwan at ang mga may trabaho ay magkaroon naman ng 100 kada araw. At istriktong pagmumonitor at pagkontrol sa presyo ng mga batayang pangangailangan ng mamamayan. Maraming po salamat at magandang araw sa inyong lahat.
Aditya, please show the second video. Thanks.
Okay, sure.
Ako po si Ate Joanne, 4 na taon ng community health worker sa Novaliches. Malaki ang naging pagbabago sa aking buhay simula noong pandemic. Dahil isa ang Pilipinas sa tinamaan ng COVID-19, naging sunod-sunod ang lockdown na nagdulot ng kawalang hanap buhay at pagtaas ng mga bilihin. At dahil bago pa man dumating ang pandemya ay hindi na matatag ang ating healthcare system, mas sumirap ang pagtugon sa COVID-19. Kasabay rin ito ang pagbabago-bago at hindi tiyak na solusyon ng gobyerno sa pandemya. Katulad na lamang ng hindi agarang pagsasara ng borders, hindi pagkakaroon ng mass testing at tamang isolation sa mga kumpirmadong COVID cases. Kung dati ay may kakapusan na tayo sa mga health workers ay mas lumala ito. Mas naging kakaunti rin ang supply ng mga PPEs, gamot at iba pang kagamitang medikal. Kulang na kulang rin tayo sa mga pasilidad at ospital na maaari sana nating magamit bilang isolation facilities. Naisasantabi rin ang iba pang isyong pangkalusugan dahil nakapokus lamang sa sugpo sa COVID-19, katulad na lamang ng pagbabakuna sa mga sanggol, pagtugon sa mga nagdadialysis, buntis at iba pang may mga karamdaman. Naging hamon rin ang pagtupad ng mga trainings, lalo na at limitado lamang ang bilang ng kalahok sa mga face-to-face na pagsasanay. Dahil hindi nabibigyan ng tamang impormasyon at hindi na ipapaunawa sa mga Pilipino ang tunay na kalagayan, ay mas naniniwala sila sa iba't ibang fake news na kumakalat. Sa kabila ng mga hamon at problema, ay patuloy tayo sa paglulunsad ng iba't ibang kampanya may kaugnayan sa COVID-19. Una, tinutulan natin ang malawakang tanggalan. Dahil alam natin na ang ekonomiya ay nakasandig sa mga manggagawa, kapag nawalan sila ng trabaho ay mas babagsak ang ekonomiya at lalawak lamang lalo ang kahirapan at kagutuman. Kasabay nito ang panawagan natin na ibalik ang mga manggagawa ng ligtas sa trabaho. Ikinampanya rin natin ang mass testing na siyang tutugon upang mapigilan ang mas lalong pagkalat ng COVID. Iginiit din natin na dapat pangalagaan ang mga health workers, ibigay sa kanila ang tamang hazard pay at pagkalooban sila ng tamang PPEs. Dahil sa panahon ng krisis pangkalusugan, marapat lamang napapangalagaan ang ating mga frontliners. Libre at tigtas na bakuna naman ang ating sigaw upang makamit ang herd immunity na siya namang kinakailangan natin ngayon. Kung may naidulot man ang pandemya, iyon ay ipinakita nito sa atin na hindi talaga natin kakayanin kung tayo ay magkakanya-kanya. Na para maiwasan ang COVID-19, kinakailangan tayong lahat ay kumilos at magmalasakit sa bawat isa. Bilang isang health worker ay nananawagan tayo sa gobyerno na makinig sa mga tunay na apektado, isang tabi ang politika at unahin syempre ang tungkulin na magserbisyo sa lahat ng Pilipino, hindi lang sa kanyang mga padrino. Unahin ang kapakanan ng mga mamamayan at hindi ang bulsa ng iilan. Gayon din, nananawagan tayo sa lahat na makiisa sa mga kampanyang inululunsad na nagtataguyod ng ating kapakanan. Patuloy tayong manawagan tungo sa ikabubuti ng bansa at ipaglaban natin ang ating karapatan sa pagkakaroon ng sapat at maayos na serbisyong medikal.
So many thanks for those testimonies from the Philippines. Again, pointing to the community health workers as the last resort in moments of crisis. Community health workers remain, and they do so in the context of considerable social tension, violence, unfavorable wider political and health systems contexts, and therefore acutely aware of their role as social agents of change. So I am now going to invite Nolutando Ntosh Tobeza, who I think has a video, has recorded her input, but she's also with us today. So I'm going to ask Tosh if you would open your video while your recording shows. Thank you.
I think there is a small technical issue there. We'll get back to that. I'll first play the video if that's
fine. Tosh, you're here. Do you want to say anything in the meantime? You've heard everything.
No. I mean, for her to speak. I'll first go with the video and then.
Oh, okay, fine.
Yeah.
Yes.
Yeah,
thank you.
Sorry. Everyone, my name is Nolutando Nontobeko Mhlongo. I am 30 years old. I'm from South Africa, in KwaZulu-Natal province, in Devon. I'm working in Phoenix Clinic. I've been in this field of being a community healthcare worker for 8 years. I started in 2013. During the pandemic, we have had so many challenges. We have been challenged so much that we even lost our co-workers along the way. And I'm one of the victims who got sick because of COVID. as since last year, July, I was tested positive with COVID. And after that, I've never been well to an extent that I have even got TB along the way. Right now, I'm taking TB medication because my lungs were disturbed due to COVID back then. So it has been a long process. But apart from that, even our system of working has been disturbed because they've added the workload for us, because we've been screening each and every household in our community. We have to screen them for COVID. Besides going door to door screening them, we have to screen like everyone in the community. So it's either we do the door to door or we're screening people who are walking around the streets. We need to screen them. So it's added on top of our work, because already we've got so much work that we are doing as CHWs in South Africa, yet our salaries are not being topped up. We are still getting the same salary, but there is more work. In terms of that, now that they have distributed this thing of vaccine, they also added on our work. They said we must go door to door again and register people who want to get vaccinated. And it was a challenge even in the household when you want to register people for this vaccine, because people were not certain, like they were not happy, and the information was not cascaded nicely. They were having questions that we were not able to answer because we didn't get proper training about the vaccine and so on. They opened the stations where they are giving vaccines. They also said CHWs, they must come and assist in these working stations. A CHW should go in a station maybe and be a marshal, but with us, we are not only marshals. We are doing the registers there. We are screening people. So it's a lot of work, and it has disturbed a lot of things. We are attending these things called war rooms. It's more like they are being paused because now we need to focus on this pandemic. Pandemic has affected us so much as CHWs in South Africa, and in all the provinces, we are crying with one cry. In terms of the PPEs, if you go around the different provinces and different communities, there are issues. Some of our colleagues are not getting PPEs. You need to see yourself, or sometimes with us in our clinic, they just give us 5 masks for 5 days. And sometimes, bear in mind, we are walking when you are going to households. As you are walking, sometimes like me, now, I'm a plus size lady. As I walk, I sweat a lot. So that mask is spoiled already because I'm sweating and now it's wet. It's not protecting me anymore anyway. So I need to have another mask as a spare mask, but I can't use another mask because I only have 5 masks a day. So it's a challenge, guys, a lot of challenges. Right now, we are facing this other pandemic that just came up. It's also affecting us as CHWs because we are not able to work. So it's a lot, and it is. I think we are emotionally disturbed with all these pandemic issues that are coming, and it's always go back to a CHW. When there is a pandemic that is coming, when there is a breakdown that is coming, they will want the CHW to attend whatever that is coming our way. Thank you so much, guys. I think this information will be relevant for this program. Thanks.
Thank you very much, Tosh. So Tosh works in KwaZulu-Natal in a particular locality called Phoenix that has in the last week or two been racked by a terrible wave of violence. And so when Tosh was referring to the second pandemic, I think she was referring to that. So thanks very much, Tosh. Community health workers, always the last resort. So we, yeah.
Tosh is also available if she wants to say something.
Yeah. Okay. All right. Well, we'll give you a chance to say something in the Q&A, Tosh. So thank you very much to all of you who've posted questions and comments. We've heard all these powerful testimonies from community health workers across the globe, many of them raising quite similar themes, many of them pointing to the centrality of community health workers actually in the response to COVID-19 and experiencing the impacts both in themselves as workers, but also confronting impacts in the communities where they work. So we are now, and the kinds of questions that are now being raised in the Q&A session relate to a number of key interfaces actually that community health workers engage in. The one interface is how they relate to the rest of the health system. So the formal health system, other health workers, there are a set of questions around how they ensure that they receive appropriate support and supplies from that health system. So that is one set of questions. Another set of questions relate to the interface with communities, the relationships with communities, how people have experienced that, but also the potential to mobilize with communities in addressing the challenges and the issues and the struggles of community health workers. And then there's a third set of questions about impacts on community health workers themselves. What happens when a member of a team dies from COVID? And how have community health workers across the globe confronted that particular enormous challenge? So I'm going to, thanks to Lauren, who's helped me assign questions, I'm really, in no particular order, going to start with the question.
Helen, could I just intervene? Could we just request all the panelists to maybe switch on their videos so that there is a discussion, a panel feeling as much as we can within our limitations. Yeah,
thanks. Tosh, would you put your video on? Okay. All right. So for Dixon, this is a question for you. How does accountability work? To whom are community health workers accountable in the hierarchy? And where does responsibility, for example, for provision of PPEs lie?
Hello, can you come again with the first question? Okay. Would you come on in the first question, please?
Do you want me to repeat it?
Yes, the first question itself.
First question.
To whom are community health workers accountable in the hierarchy of the system? Who's responsible for providing PPEs?
Okay, thank you. Obviously it's the government, and if I mention the government, then it's the Minister of Health who is responsible to provide all these PPEs to its community health workers. And if you go down to the volunteers, they also depend to the same ministry. They have to provide all the necessary materials for the work to be done accordingly. So in short, it's the Minister of Health. To those who work at the non-governmental organizations, they are also responsible for their own people. They are supposed to provide those people PPEs to their employees. So that's how it works here in Malawi. On the second question, you said, how do we? Can you come again? Sorry for that.
You have answered the question. Thank you so much, Dixon. We'll come back to you. Okay. So what I'd like to ask the panelists, just to indicate with your hand, if you want to chip in and join the conversation on any of these questions. Please feel free. Okay, so let's see if we can make this some kind of conversation for the next 15 minutes or so. So Sureka, is Sureka with us? Sureka, you are with us still. Can you tell us about the deaths that have happened amongst ASHA workers and whether that they have been compensated? Perhaps you can talk a bit about how the ASHAs have themselves been impacted by COVID.
सुरेखा जी, आप वहाँ पे हो?
Gargaya? Yeah, do you think Sureka got the question? Or
Yeah, Sureka जी, ये कॉम्पेंसेशन के बारे में पूछ रहे कि आशा जिनका मृत्यु हो गया उनका कॉम्पेंसेशन के बारे में। और
हाँ जी, ये केवल हरियाणा के अंदर ही 10 आशाज की डेथ हुई है कोविड से और वो कोई कंपनसेशन नहीं मिला। और ऑल ओवर इंडिया में 80 के आसपास हैं जो आशाज हैं जिनकी कोविड के टाइम पे अभी डेथ हुई है और उनको किसी को भी ये कोविड का कंपनसेशन नहीं मिला। फर्स्ट वेव में एक आशा की डेथ हुई थी मध्य प्रदेश में, हमारे उसको कंपनसेशन मिला था फर्स्ट वेव में, लेकिन सेकंड वेव में जितने भी फ्रंटलाइन वर्कर्स हैं सबको ही ये मुश्किलें पेश आई हैं। उसमें भी क्योंकि वो मैंने पहले भी बताया कि जैसे सबसे निचले पायदान पे आशाज काम करती हैं हेल्थ स्ट्रक्चर में, तो उनको इसमें सबसे ज्यादा परेशानियों का सामना करना पड़ रहा है।
To just sum it up, basically Sureka was saying that there were 80 deaths and none of them were compensated. Only 1 or 2 persons got compensated in the first wave. India just completed its second wave of the pandemic.
okay, so this question is for you, Carl, and also for you, Tosh. I'm interested to know whether community health workers in the countries represented here today found it necessary to self-organize their own responses to COVID-19, perhaps with other community members, care workers, organization, but outside of what the state was offering in the formal health system. What forms did such collaboration take, if it happened? So it's about the self-organization of community health workers and their alliances with community structures and organizations.
Yeah, I suppose in Australia, when COVID first hit our shores, you know, there was a lot of unknowns about COVID. Our community health workers, you know, they were very instrumental in ensuring that our elders were protected, our elderly, and that also went up to the community leaders, who then went on to some national Indigenous community leaders to actually lock down. We implemented the Biosecurity Act, which means remote communities were actually locked down. So they had police and army manning the entry and exit of community in order to keep them safe. So at the beginning of COVID, because of the unknowns, we wanted to protect our elders, our knowledge holders. And as I said, you know, they're the libraries and the universities of our communities in order to pass down that information to the next generation. So community health workers were quite instrumental in ensuring that health services were still delivered even when it was locked down in our communities.
Thanks, Carl. And Tosh, did you want to add to that? And Mateus, you opened your video. If you want to also contribute, please do. Tosh, over to you. Okay, we'll come back to Tosh, I think. Okay, we're struggling to hear. Yeah, we're struggling to hear that. Okay, in the meantime, here's one for you, Kate. We'll come back to you, Tosh. Kate, how to connect with PSI's budding work in Africa, you know? Can you share your work? What is your view about how to build a mobilization, actually, that is truly global and international? So over to you, Kate, or Benin, whoever would like to contribute. Yeah.
Yeah, I mean, certainly we are really keen to collaborate with any other groups. There's obviously a lot of groups that are mobilising to support community health workers, a lot of self-organised unions and groups, not always recognised by governments as unions, but certainly self-organised workers groups. And so we're keen to collaborate. I mean, we have a number of, Benani, I think, put up some material on a connection to some of our material on our website. But also, you know, we have other sort of ways of coordinating amongst the unions, and it'd be great to bring in and connect with others. In terms, I think it really is the time to build that work globally, because, you know, obviously at the moment, the world, there is a bit more recognition of the importance of health workers, and if we don't get governments to put in more money to public health now, well, we never will. I mean, of course, big corporations are still looking at the ways they can extract as much money out of health systems as possible, but now's our best chance. So we do need to mobilise as much as possible, despite the restrictions that we have. I mean, obviously, community health workers have gone on strike in a number of countries in order to achieve what they can. We've had more nurses unions as well. One thing we want to do is really connect the formal and the informal, so connect things like the health workers unions, nurses unions, and see that, you know, that we need this solidarity to strengthen community health workers, and to support their demands, because you know, formal unions are also struggling with issues around COVID and their recognition, but together they can be stronger. So that's something I think we want to do more of in those other unions. And the International Labour Organisation review I mentioned is one way to do that, because that instrument defines the differences, the different categories of nursing. It has three, so registered nurses, you know, sort of enrolled nurses, and then the third, which it's a very old, it's a convention written in the 70s, but it says nursing aides, which some of that work does fall into, you know, the role of community health workers. And by defining that, we think that's an opportunity to show that together they, you know, that they should be covered by these international instruments, and that we should be able to coordinate mobilisations together across health worker unions. But yeah, on the specifics of Africa, I did put in send my colleagues contact Nadira, you know, who's working with those unions in the 3 countries. And of course, we're always happy to hear from anybody else in the People's Health Movement, and to look at other ways to collaborate.
Great. Benani, do you want to add anything?
No, thanks, but Kate has already summed it up, and we are looking for much broader solidarity all across, and also to have stronger collaborations in country specific, with the country specific unions and the movements that have been working with the community health workers. Because one aspect that we see is that there has been many smaller groups, unions who have been actually working with the community health workers whom we do not know of, or who are we have not been in direct contact with, but we would really like to get in touch with them or get in touch with us, because we need a very strong union movement to put forward a demand for recognition of the community health workers as workers.
Great. Thanks, Banani. Okay, Carl, here's a question for you. So could you talk a little bit about Aboriginal community-controlled health services and how they offer a better environment for health workers than mainstream workers, and maybe that has a parallel in the SUS, actually somewhere in Brazil. But over to you, Carl.
Yeah, thank you. I was just typing the answer in the Q&A, so I'm just probably going to repeat that answer. So Aboriginal community controlled in Australia, when we look at the governance of it, so we have a primary healthcare centre, it's governed by a local community board. So they're all Indigenous people that are actually making decisions about the health needs and the strategic direction of that community in terms of addressing whatever health issues. So it's basically Indigenous people making decisions for Indigenous peoples, and they're locally elected. So that's the model of Aboriginal community control. With the Aboriginal health worker that works particularly in that community, they have the cultural intellect or the cultural knowledge of that community and the environment that they work in. Cultural safety, a lot of our people feel comfortable in accessing Aboriginal community controlled health services because, it's governed by an Indigenous board, which means, the cultural safety, they're not treated as a number. They're actually treated as a person. And so the Aboriginal health workers generally are from that particular community. So they know the community inside out, they know the relationships, they know the cultural protocols and practices. And that's why we see that better health outcomes are achieved when our people are involved in the care of our people. It's a bit of a long-winded answer, but...
No, well, it's totally appropriate. Thank you. Yeah. Okay, and Tosh, I don't know if you're able to unmute now, and you can contribute anything you want. Gogea, can you unmute Tosh?
Hi, yeah, can you hear me?
Yeah, we can hear you.
Oh, okay. No, I'm saying thank you for this meeting. We're also struggling this side. Sometimes we don't feel safe. Right now, there's this violence that is going around. People are looting everywhere, and the communities that we are working in that has two diversities. It's giving us trouble. It's still a problem for SHW here in South Africa. We sometimes not safe. Some of our colleagues are getting bitten by the dogs. Some of us are being raped. Some of us passed away and nothing has been done. It's a lot. And we are still backward in South Africa. Yeah, I think that's what I can contribute. Yeah.
Okay. Thanks very much, Tosh.
They're always pushing for statistics and numbers. They just don't care about SHW, the government itself.
Yeah.
Yeah, thank you so much.
Okay. Thanks, Tosh. Good. So we need to now hand over to Sulakshana, who will talk a bit about what all this means for PHM going forward. But just to warn you panelists, I will then give each of you a turn after that to give your last take-home message from today's webinar before we close. Over to you, Sulakshana.
Thanks, thanks, Helen. So I just wanted to present on behalf of PHM. As you all may know, PHM, the People's Health Movement, is a global network bringing together grassroots health activists, civil society, academic institutions, and we are currently there present in around 70 countries, and we are guided by our People's Health Charter, and are committed to comprehensive primary health care and in addressing social, economic, environmental, political determinants of health. So as Lauren has explained previously, the webinar was organized by the Health Systems Thematic Network, thematic circle, which is part of our Health for All campaign. And the objective was to bring together community health workers from different countries and the unions, in addition to activists, academics, and health practitioners, to reflect on, what the pandemic that CHWs have been building resilient health systems as part of our vision for Health for All. We strongly believe that, universal health care with a comprehensive primary health care approach needs CHW, and CHWs to be able to do their jobs, to have employment conditions, respecting universal healthcare system. And we also recognize that the struggles of community health workers and other workers are basically related to undermining, weakening of the public sector and the struggles that we have against privatization and commercialization of the health systems. We therefore emphasize that there needs to be a public recognition of the fact that dismantling of public health systems and labor rights has been devastating for health systems, health workers, and finally for people's health and well-being, as also we have seen in the pandemic. Therefore, as conversations move towards COVID recovery, and while we intervene on the immediate impacts of the pandemic on health workers and the health systems, we feel that a discourse emphasizing the significance of public systems and services, changing the political power relations, and towards social justice, equality, and fair redistribution of economic resources must be at the crux of any long-term vision and struggle. And we have the Health System Circle has an upcoming paper discussing some of these issues with support from the Global Health Justice Partnership of Yale Law, and we hope to share that with you very soon. But as an outcome of this webinar, we plan to first use this webinar to the recording to develop a podcast and also develop versions with different translations, subtitles for wider dissemination and discussion, so that the experience that, the rich experience that we have been exposed to during the webinar can reach more people, including governments, WHO, and other global institutions. And many of our regional and country circles are associated with community health worker unions and working with them. And we would like to now develop a PHM global position paper on the rights of CHWs that would help to inform our work on this issue. And we would invite everybody who's here, especially the community health workers and the unions, to contribute to it and help us build this paper. We are committed to building solidarities with CHWs and their unions and amplifying their demands, especially within the wider context of our struggles for strengthened public systems. We welcome you to contribute to the struggle and this understanding, and you can get in touch with us. I'm just sharing a screen as we go into the concluding session. So you can get in touch with us on our website. This is a Health for All campaign. This is the paper that is about to be published in a couple of weeks. And this is our contact information. And finally, we would request, of many of you would know that our comrade Shata Uday has been arrested by the Israeli occupying forces on 7 July, and we have a sign-on letter requesting WHO to intervene for her release. So I would request you, I will just paste the link on the chat and would request all of you to please sign as individuals and organizations. Yeah, thank you.
Thanks, Sulakshana. So in the last 10 minutes to us, we are going to give each of you, the panelists, a chance to give us your take-home message, but also what might be your top demand, actually, as CHWs. Dixon, you're unmuted, so you go ahead, sir.
Okay, thank you so much. First thing, let me thank you, everybody, for watching and participating in this meeting. For me, I've got 3 or 4 things that I would request for our governments to do for us to perform accordingly. The first thing is to recognize as community health workers as the backbone of the health system in our countries. So they need to support us in providing us with PPEs, transport, and all other things that are needed for us to perform effectively. And the other thing that I would wish is for our governments to consider those volunteers, community health worker volunteers. At least they should be considered with some of the incentives so that they can perform. Because right now they don't get anything. But if they are considered with something, maybe they can perform to their best. The other thing that I would request is for us community health workers. Here in Malawi, they are called, most of them are HSAs, health service assistants. Their training is only 3 months. So 3 months is just very, very small period for somebody to perform at the ground. So if I would wish, our government to consider the time of training. Maybe it should be from 1 year going upwards. Maybe this would help to our communities to get the real deal of community services. The other thing that I would wish is for trainings. Community health workers are not trained in various activities. Volunteers are just sent to perform without any training. So I would wish our governments to consider this so that we do as required by our communities. Thank you so much.
Thanks, Dixon. So you're arguing for the basic conditions of decent work, really. Yeah.
Yes.
Thank you. Okay, so Sureka, are you able to address us?
हेलो
हाँ सुनाई दे रहा है
क्या रिपीट करेंगे एक बार क्या आप पूछ रहे थे
आपका एक डिमांड या आपका एक टेक अवे जैसा है कुछ बता दीजिए
हमारी डिमांड है कि आशा वर्कर्स को हेल्थ कम्युनिटी हेल्थ वर्कर के तौर पे उनको दर्जा दिया जाए उनको एक परमानेंट एम्प्लॉइज बनाया जाए और मिनिमम वेज 24,000 दिया जाए
Thank you.
Great, thanks. Very clear. I think, Gagaya, I don't know if we got translation. I didn't, but
translation is going on, but basically the recognition as workers and a minimum salary of 25,000 Indian rupees is something she would like to put as a single demand.
Okay, thanks. Carl?
Yeah, I suppose I've heard a lot around the hierarchy, you know, the community health workers being very much at the lower rung of the hierarchy, you know, that's the same in Australia. You know, the profession isn't actually valued or respected a lot of the times within the hierarchy of other health professions. However, we know that our communities value the role of the community health worker. So the valuing of that role by the community, we know that our job doesn't finish from 9 to 5. We're often called upon on the weekend to do a lot of work outside of our normal working hours, and we don't get paid for it. You know, we know that the community respects our role and they value our role very, very highly. So I think, you know, as a whole, you know, we should really be looking out for our community health workers, their social and emotional well-being, you know, taking care of themselves as well, because they give a lot to our community, but they don't often take care of themselves and have time out, you know, and do the self-care for themselves. So we need to consider, you know, our communities, our community health workers, you know, their own self-care. So yeah, that's probably the take-home message I'd like to leave.
Thank you. Tosh.
Yes, hello. I'm hoping one day our government can just recognize us and also put an increase to our payment, because the money that we are working for is just making me feel ashamed of even being a CHW in my country, because we do a lot of work as much as it's voluntarily, but our families need to survive at the end of the day. So that's our biggest concern, because we're always working on contracts. We are always promised permanent, but it never happens. So it makes you wonder until when, because I've been in this field for like 8 years, as I was sharing before. But even if I can just retire, I'll go home with nothing. Even if I die, my kids will get nothing, you know, but I wake up every morning and help each and every person from my community with love. But at the end of the day, I need to earn some living, because the money that we get is just a peanut. That's the thing. I hope one day they will reach to an agreement of raising our salaries and making us permanent, because always now it's even 1 year contract. You sign the contract on March, next year you come back again and you sign. And we can't even open our own companies. If I want to open a company, they will tell me that I'm under Upezal system, I'm working for government. That money that no one can survive with. Yeah, I think that's it.
Okay, thanks very much.
Thank
okay,
you.
so before I ask Kate or Benani just to say something, Mateus, would you like 30 seconds? And then Jamie, I'll ask you. Yeah.
Yeah, thanks, Helen. I just would like to thank Katia from Brazil again for delivering her message. I think this motto of hers, living and winning and learning every day, it's something very important, is the base of our system. And this is all the potential of community health workers and how they should be vetted. Brazil has a great experience on that to show the world, and we hope we continue struggling and getting better on that. Thank you very much.
Thank you. Jamie?
So I'd like to thank all the panelists here who have represented community health workers. It's a side we don't really hear much about in healthcare delivery, and especially here in the Philippines. So the context here is there are people under the government called barangay health workers, but they only get honorarium. So again, like stated earlier, it's not a livable wage, but there are a lot of responsibilities in terms of healthcare delivery, contact tracing, for example, and they're exposed to a lot of dangers, especially because of the pandemic. And they're sort of part of the informal sector, but now, especially when we're depending on them, they should get the recognition that they deserve, of course. And for countries like ours, it's also hard to move, especially if our community health workers also call for even just basic, what do you call this? The
rights.
Yeah, the rights and the social and financial support our communities need, especially with the laying off of the workers. Thank you.
Welfare, yeah. Okay, thanks, Jamie. All right, Kate or Banani, you've got 30 seconds.
I'll give it to Banani.
I would just like to echo what all the panelists and the participants have said. And just 3 words: we need to recognize the community health workers' work, we need to regularize them as public healthcare workers, and we need to remunerate a decent living wage for them. And we can achieve that with building a strong union movement all across. Thank you.
Fantastic. And I think that summarizes the sentiment, the comments in the box. Yeah. So thank you very much to all the panelists and to all the participants, to everyone who's contributed questions. It's been a fascinating, inspiring, and extremely informative session. So thank you to all of you and to PHM. And I'm now going to hand over to Deepika, who is going to formally close today's event. Thank you.
Yeah, I would like to thank all the speakers who joined us today. Surekha, Dixon, Carl, Kasia, Amy.
Can't hear you very well. Could you
Can't hear me. Sorry, is this better?
If you can, yeah, this is better.
Yeah, we would like, I on behalf of PHM and the Health System Circle would like to thank Surekha, Dixon, Carl, Kasia, Amy, Joanne, and Tosh who joined us today and agreed to speak today. I would also like to thank Helen, the moderator. Also our PHM members from different countries who helped us a lot, put us in touch with different movements and the community health workers. So I would thank Wilson, Matthews, Jamie, and Fran. And Matthews and Jamie have helped a lot with the videos and the subtitles, etc. Put a lot of efforts there. I would like to thank Lauren, Linda, Sundar, Sulakshna, and other people in the health systems group and people who helped us, start with the webinar. I would like to thank the interpreters, Sangeeta, Max, Audrey, and Priyam, who did the translations for us today. PHM Secretariat, I would like to thank Gargia for the very efficient coordination. And finally, no, not final one, the participants from across the world. It was a very, very varied group that we had today, and thank you for your time and your attention today. And lastly, the community health workers who, continue to work and despite such challenging circumstances, and at the same time, the challenge continue to also challenge those conditions and circumstances. So we have a lot to learn from them. Yeah, so that is it. Thank you, everybody. We can close.
Thank you. Bye, everyone.
Yeah, bye.
Thank you.
The video will be uploaded on PHM's YouTube in a day.
Yes.
Everyone.
Thanks, everyone.
Just to announce that the video recording will be uploaded on the YouTube channel of PHM. We'll circulate it later.
Thanks.